Hi, everyone. Welcome back to Neurospicy Nursing. It has been a while. Um, your girl is busy. She graduated nursing school, and I will still be helping you guys through my residency and through taking the NCLEX, all the things. So, all the tips that you need, your girl did it, and she did it in 16 months. Um, so, I'm still here to help you guys, and I'm going to teach you this material in hopefully a way more conducive way than how you learned in nursing school or currently learning in nursing school. Today's, we're really diving into OB and kind of the beginnings of everything. There are a few, oops, um, there are a few specific content topics that I would like to cover here, including the prenatal period, the different signs of pregnancy, Nagel's rule, the psychological changes that you go through pregnancy, and the systemic changes, as well as what a fundal height measurement is and GTPAL. A lot of these all kind of correlate for that first test that you guys will have in OB as long as they don't put you backwards. So the prenatal period, this is kind of going more into anatomy, but I just wanted to cover it just in case, anatomy wasn't your thing, and you're not super confident about this type of material. So the prenatal period, it begins um, at conception and ends before birth. So it's going to cover all of the pre-embryonic, embryonic, and the fetal stages. Conception occurs specifically when the sperm fertilizes an ovum in the fallopian tube. Now, we'll learn later this semester that there's something called ectopic pregnancies, and that's when that fertilized egg implants in an improper place. Hormones here are going to be FSH, LH, estrogen and progesterone, and HCG. Um, all of these hormones help regulate ovulation and early pregnancy. The male anatomy doesn't really help much in pregnancy. Mine is contributing sperm, which is produced through the testes, transported through the vas deferens, and it's suspended in that seminal fluid, which helps really nourish and protect those little swimmers. The post-fertilization phase is when the embryo implants itself and the placenta begins to form. So the placenta, it's important for gas exchange, for nutrients, and for waste. Don't forget the amniotic fluid, though, is basically fetal urine, right? So that is not what we mean by waste in this case. Also remember that maternal and fetal blood do not mix, and the exchange is occurring just by diffusion. By doing this, it's going to protect the fetus and allow for oxygen and nutrients to pass through. Here's the second portion of this lecture, the different signs of pregnancy. So these are the presumptive signs of pregnancy because it's specifically relying on what the patient is reporting and what they suggest is pregnancy, but it's not a diagnosis on their own. Amenorrhea is one of the first presumptive signs of pregnancy because your patient has now missed their period. It's, of course, completely subjective, and sometimes a missed period can be caused by something else. And what's important to remember is that in pregnancy, the lack of the period reflects early hormonal shifts, mainly the rising HCG, and progesterone. Fatigue is also very common in early pregnancy because of that increased progesterone, and as well as the higher metabolic demands and the blood volume expansion. But again, it's very subjective here, but it's also very typical. Nausea and vomiting tends to happen because of the increase in HCG and estrogen. sorry, estrogen, would stimulate the um, chemoreceptor trigger zone. It's really what causes that nausea. If you remember in Farm, we talked about antiemetics blocking CTZ. This is that zone that we're talking about, that's CTZ. It peaks around 8 to 12 weeks, and it's one of the most classic early pregnancy symptoms. You also will see urinary frequency as a presumptive sign because increased blood flow to the kidneys boosts urine production. And later in pregnancy, the uterus is compressing on the bladder, like if they were to have a cryptic pregnancy when you can't really tell that someone's pregnant. Um, it's compressing on the bladder, but again, it's subjective and can commonly be mistaken for a UTI. There's also going to be quite a few breast changes, including breast tenderness because of the rising in estrogen and progesterone, because it's starting to prepare the breast tissue for lactation. Patients will often describe this as fullness, heaviness, or sensitivity. There's also other breast changes that include the darkening of the areola, the enlargement of the Montgomery tubercles, and increased visualization of the veins. Again, all of these are hormone driven, so they fall under presumptive signs. And then there is the quickening, which is the patient's first awareness of fetal movement, which happens between 16 and 20 weeks. If they've been pregnant before, they may notice that quickening a little bit sooner, but it's still presumptive because it can be mistaken for gas or bowel movement. Oops. There is also probable signs of pregnancy, which is objective. So there's cervical changes, which are objective findings that a provider can see or feel, but they are not diagnostic because other conditions can cause similar changes. Hagar sign is the softening of the lower uterine segment. It is objective because, again, the provider can see it, but it's not a true sign because it can also happen with pelvic congestion, hormone fluctuation, certain gynecologic conditions, so it's not necessarily exclusive to pregnancy. Chadwick sign is the bluish discoloration of the cervix and the vaginal walls. It is not a true sign either because any increase in pelvic blood flow, like a bad infection, pelvic tumors, and sometimes even rigorous intercourse or um, non-consented intercourse can cause similar discoloration. Godel sign or Goodell sign, not sure how you want to pronounce it, but it is also the softening of the cervix, and it's because of increased estrogen and vascularity. But cervical softening is seen with so many different hormonal contraception, chronic inflammation, and cervicitis that it can't be a definitive sign. There's also ballottement, which is when the examiner taps the cervix and feels a rebound. And it's like tapping a floating object in fluid. Not a true sign, though, because there's uterine fibroid, polyp, and ovarian masses that can create that same type of rebound sensation. Braxton Hicks are irregular and painless contractions that don't cause cervical changes, which means that they're not dilating. They're more common in the second and third trimesters, though. Some people can feel them earlier, but it's not a true sign because there's certain things like uterine irritability, dehydration, stress, or UTIs that can cause this. And then a positive pregnancy test. You would think that this would be a definitive sign of pregnancy, but it's actually not because there can be increase in HCG levels in urine or blood because of molar pregnancies, choriocarcinoma, which we'll go into a little bit more later on this semester, certain ovarian tumors, and some GI cancers that can cause a positive pregnancy test. Also, there could be user error using the test, a faulty test, that can also be positive. Really, the only way to definitively say that someone is pregnant is through an ultrasound or through fetal heart tones. And here it is. We're talking about those fetal heart tones. We can see the baby on ultrasound visualization, as well as the examiner can feel fetal movement. Those are all going to be very, very important for us to positively say that someone is pregnant. Next is Nagel's rule. So Nagel's rule is a way that we can date pregnancy. It's the last menstrual period plus 1 year minus 3 months plus 7 days. You can do it however way you want. I just like to go from years to months to days. It makes more sense in my brain to go linear like that. Some people add the days first, then the months and the year. It all kind of amounts to the same thing. But the problem with this rule is that it's only about 5% accurate, which means that only 1 in 20 babies are born in their calculated due date. It's not very accurate because it's going to assume that the individual has a perfect 28-day cycle. And it assumes that ovulation is happening exactly on day 14, which isn't true for majority of women. It also is not accounting for that most cycles lengths vary from 21 to 35 days, and the ovulation timing shifts based on those cycles. It also doesn't account for any late or early ovulation, and ovulation that can happen earlier or later each month because of the shift in their menstrual cycle. It also doesn't account for something called implantation timing, which can take anywhere between 6 and 12 days after fertilization, which also changes how the HCG is rising and the accuracy of dating. The last menstrual cycle also, they may be uncertain on, or it can be inaccurate because some patients don't have regular cycles, don't track their cycles, and can mistake spotting for an actual period. Ultrasound is going to be the most accurate for first trimester, especially between weeks 8 and 12. And it's more accurate because it can actually measure the fetal growth. So I have some questions here for you guys. Go ahead and pause the video here, solve this, and the answer is going to be on the next slide. All right, here is the answer to our Nagel's rule. So they were March 10th, 2026 for the first one. So if we add a year, it brings us to March 10th, 2027. If we subtract 3 months, we're in December 10th of 2026. Sorry, that's supposed to say 2027. And adding 7 days is December 17th of 2027. So the estimated date is 2027. Sorry about that, guys. The second one is correct, though. If their last menstrual cycle is August 25th of 2026, we add a year, we get August 25th, 2027. Subtract 3 months, we're in May of 2027. Add 7 days, you're June 1, 2027, which is my dog's birthday. One of my dog's birthdays. All right, the psychological changes. There's 3 main ones that you are going to need to know for your test. Ambivalence is the first one. It happens early in pregnancy, and it's that feeling of mixed emotions, right? You don't know whether you should be excited, fearful, detached, and it's completely normal. It reflects the psychological adjustment to the idea of being pregnant. And during this time, patients are going to look for reassurance from family members, friends, partners. And our job as nurses is to make sure that we normalize these feelings and we assess the level of support that they have at home. Acceptance. This is normally in the second trimester. The patient starts to shift into the acceptance phase. Fetal movement usually makes pregnancy feel a lot more real for people, and their emotional stability will start to improve as their hormones start to stabilize a little bit. Um, they also may still have some lingering mixed feelings, but overall, they're going to start to feel really integrated into the pregnancy. This is a great time to assess how they view their fetus. Do they view it as a baby? Do they still view it as a pregnancy? Or do they just view it as a huge financial burden? Because it's going to help give insight into how this individual is going to be able to bond and cope with this child. The last stage is preparing for birth. It happens in the third trimester. Patients are entering that down to the wire phase or the nesting and planning stage. They're going to focus on the signs of labor, newborn care, feeding decisions, how to make their home safe. They're also going to have some anxiety around their delivery. We have to make sure that we educate them and reassure them. And we're also going to guide them through what to expect, how to prepare, and how to recognize when it's time to seek care or delivery. All right, on to the next one. Our system changes. So there are many different system changes that can happen. They can start to occur as early as the second trimester. And we have three big ones here at the bottom, but they're not limited to this. There are other changes like just regular old hyperpigmentation, acne, and visible veins. For stretch marks or striae, it's because of the rapid skin stretching, because of hormone-driven weakness, as well as, you're growing a human being. We have to make sure that we are telling our patients that there's not going to be any cream that really prevents them. I know a lot of people say that cocoa butter can really help, but it's not going to prevent them necessarily, but they'll end up fading from red to purple or to silver over time, or they may just go away after they give birth. The next one is linea nigra. It's a dark line down the abdomen that's caused by an increase in melanin production. It's completely normal. It's a lot more noticeable on darker skin tones, and it's going to also fade after delivery. And then there's melasma or chloasma. It's nicknamed the mask of pregnancy because estrogen and progesterone stimulate melanocytes, and they end up showing up as dark patches on the face, and they get even darker with sun exposure. So they are common, they are harmless, and they can fade postpartum, and usually do fade postpartum. Then we have breast changes. We're going to start with breast enlargement. There's a fullness and enlargement that happens because of something called glandular hypertrophy. It's driven by pregnancy hormones. And we're going to really encourage our patients to wear a supportive bra. Striae, again, stretch marks. It's due to stretching, the hormones making the skin a little bit thinner, as well as the increasing milk production. Again, nothing's going to prevent them. Over-the-counter products don't prevent them. Breast tenderness, it's hormone related. We need to ensure our patients that the sensitivity is expected and it's going to improve with good supportive bras and breast care. And then colostrum, the liquid gold. Colostrum may start to leak as early as 16 weeks, so we need to teach the normalcy of this. And if they decide that they're going to breastfeed or be pumping, make sure that they're doing that. Also, gentle nipple care and keeping the area clean and dry. There's also respiratory changes that are associated with pregnancy. One of the main reasons is because during pregnancy, your total blood volume is going to expand by 40 to 50%. Just think about that. That's a lot of fluid. And now, because of that, your heart has to pump that much more fluid per minute to supply the placenta. The lungs come in because the extra blood flow can cause mild congestion in the blood vessels of your lungs and the upper airway. So think of heart failure, how you get that pulmonary congestion. You can hear an S3 sound. That same thing is going to happen here. But the result of that pulmonary congestion is that the tissues inside of your airways swell a little bit, and it makes your lungs feel a little bit stiffer, and it makes your brain think that you are dyspneic. There's also mild hyperventilation, which is a hormonal trigger. Many people assume that they're breathing faster because the baby is crowding them and pushing on all of their organs, but it's actually starting all the way in the first trimester, long before the uterus is extremely large. And the culprit in this case is progesterone because it is a direct stimulant to the respiratory center. And it's essentially telling our body to lower the amount of carbon dioxide in our blood. And as a result, we're going to take deeper breaths, increase the tidal volume. And even though you're getting plenty of oxygen, this constant drive to take deep breaths feels like you're having air hunger. There is also diaphragm elevation. It's the mechanical trigger. As pregnancy progresses into the second and the third trimesters, the uterus, again, it's pushing up on all of those abdominal organs. The shift is also causing your diaphragm to get pushed up as much as 4 centimeters. To compensate, your ribs will flare to give your lungs more room. As a result, diaphragm is pushed even higher, and its overall movement is then restricted because it can only stretch so much. So it feels like you can't take a deep breath. It feels unsatisfying to take a belly breath because you feel like you can't get any air, and you'll have to rely on your chest a lot more heavily to breathe. And then increased oxygen demand. It's your metabolic trigger. Your body's metabolic rate increases significantly, up to 20%, when you are growing a fetus. Because of the placenta and your own hardworking organs, there's just so much going on. It's normal for you to feel like there's that increased oxygen demand. Also, with the respiratory changes and that circulating fluid, it may be easier to tell your patient to sleep propped up or sitting up just to help with some of that fluid volume. And all of this, especially before the first 38 weeks. The first 38 weeks, you're almost done with your pregnancy at that point. But I say 38 weeks because after 38 weeks, there's something called the lightening, which is when the fetus starts to descend the pelvis. So it's going to take some of that pressure off of mom's organs and off of the diaphragm and off the lungs so they can breathe a little bit easier. Now, there are some normal versus red flag dyspneas in pregnancy. One of the biggest things to remember here is that pregnancy is a pro-clot and high volume, high demand state, okay? So symptoms that seem like they're just dyspnea can actually be a PE, a DVT, cardiac strain, respiratory failure, and they progress a whole of a lot faster in pregnant women. So things to keep in mind. Sudden severe dyspnea is going to be completely abnormal, okay? Because in pregnancy, there's increased clotting factors like fibrinogen and factor 7. There's also venous stasis. So any abrupt shortness of breath may signal a pulmonary embolism. Chest pain and palpitations. The increased blood volume and the cardiac workload raise the risk of cardiac complications like arrhythmias and pericardium cardiomyopathy. We'll get into that a little bit later on. Coughing up blood or wheezing can indicate a PE, severe infections, or even both of which are going to progress faster in pregnancy due to the changes in the immune system as well as the circulatory system. Dizziness and fainting Pregnancy is going to lower systemic vascular resistance. We're going to talk about this in the next slide a little bit more. But because of that decreased systemic vascular resistance, it can actually end up masking signs of early shock. So syncope may reflect respiratory or cardiac compromise. Also, unilateral swelling, estrogen, and venous compression from the uterus dramatically increase your risk of a DVT, and a clot can embolize obviously in the lungs, which creates a PE or a stroke. Blue lips and fingers, so cyanosis, it signals impaired oxygen, which is never normal, ever, never, ever normal. Can be a PE, severe cardiopulmonary disease. So the cardiovascular changes, we went through some of these in the last slide. I'm just going to go into them a little bit more in depth. So fainting and syncope, vasodilation, and decreased venous return can reduce blood flow to the brain, which is what causes the dizziness or the fainting. So it's very important for us to teach our patients to change positions slowly. Avoid lying flat on your back after 20 weeks and eat small, frequent meals to prevent drops in blood sugar and sodium. Venous stasis. The uterus is compressing the pelvic veins, and progesterone, which ends up relaxing the vessel walls, causes varicose veins, swelling, and edema. So we have to make sure that we teach our patients to elevate our legs, avoid crossing them, and use compression socks, as well as walking frequently to promote circulation. The increased heart rate. Heart rate for a pregnant woman can increase from 10 to 20 beats per minute, which can sometimes also feel like palpitations. So make sure that you teach them this is completely normal. Please hydrate and avoid stimulants like excess caffeine. That decreased systemic vascular resistance I talked about in the last slide. Again, progesterone relaxes blood vessels, so it lowers the resistance and makes circulation easier, but it's going to cause dizziness. So we are still going to teach your patients to make sure that they are slowly getting up from sitting or lying down. Avoid standing still for long periods of time or sitting for long periods of time, and make sure that they maintain good hydration. The increase in blood volume, again, it can increase up to 50%, which is crazy, to support the placenta and protect against blood loss at delivery. We're going to get into postpartum hemorrhages later on this summer semester, so just stay tuned for that. Patients also may notice that they're feeling a little bit more puffy. They may look puffy. They may have swelling in their feet. So we're going to encourage hydration. Again, position changes are so important. Elevating the legs are also super important for reducing that dependent edema, as well as those compression socks. See how a lot of the things correlate with each other? Cardiovascularly, we're going to teach a lot of the same things. It kind of doesn't matter what they have. We're going to avoid standing or sitting for a long time. We're going to make sure that we're circulating our blood. We are going to lift our feet up, reduce the edema, all the things. Okay, anemia. So when you're pregnant, your plasma volume is going to increase, but your red blood cells don't as much, or they may not at all, which in turn is going to dilute the hemoglobin and it's going to cause anemia. So we have to make sure that we reinforce prenatal vitamins. Prenatal vitamins are so important for preventing neural tube defects, and we're going to get into that later this semester as well. But preventing the neural tube defects, we're also going to tell them iron-rich foods, make sure that they're taking an iron supplement, and take it with vitamin C first thing in the morning, empty stomach, for proper absorption. Increased cardiac output. So the cardiac output for these patients ends up rising because the heart pumps more blood with each and every beat because of that increased circulatory volume. This is why patients will tend to feel a little bit more easily winded. So we're going to teach them to pace their activities, give themselves proper rest, avoid overheating. So make sure that you are not out in the sun for 50 billion hours while you're pregnant. And if you are, hydrate, 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 electrolytes, hydrate, and put something cool on you. And lots of sunscreen. Also, make sure that you rest. Even if you're not short of breath, you still need to rest. You're not going to be completely bedridden, obviously. You can still do stuff in pregnancy. There are times where you are bedridden. We'll get into that for the complications of pregnancy, but just give yourself a little bit more rest. And then decreased blood pressure. You would think that because of the increase in the circulatory volume that your blood pressure would increase, but it's actually not true. The blood pressure is going to naturally drop in the middle of your pregnancy because of that vasodilation, and then it's going to return back to near baseline in the third trimester because of all that fluid volume. We're also going to teach our patients, again, slow movements because of that decreased blood pressure, adequate fluid intake because of that decreased blood pressure. But if they are having any severe headaches or vision changes, this is a red flag because we're going to be worried about preeclampsia because, again, remember, your blood pressure is supposed to decrease, not increase. All right, there's also some GU-GI changes or GI-GU, whatever you want to say. The first one that we're going to go over is nausea and vomiting. So we talked a little bit about it before, but HCG and estrogen stimulate that chemo trigger zone, which is why nausea tends to peak around 8 to 12 weeks. Very common in that first trimester, and it's going to improve when your hormone levels stabilize. So make sure that you tell your patients 5 to 6 small meals a day. Don't eat huge meals, it's just going to make you more nauseous. Avoid anything fried. Avoid anything spicy. Avoid anything that's odorous. And make sure that they're monitoring their weight. Make sure that they are monitoring their urine output. Also, if they cannot keep food down for more than 24 hours or fluids down for more than 24 hours, have dark urine, palpitations, dizziness, they have to make sure that they call their provider. The next one is heartburn. So, progesterone is a dilator, right? We talked about this before. It's also going to dilate and relax that lower esophageal sphincter. And since that growing uterus is pushing all of those organs upward, it's also going to cause anything inside of those organs to get pushed upward, i.e., your stomach acid into your esophagus. So, reflux is very, very common. Make sure that we're teaching them sit upright for at least 30 minutes after meals. We're still going to avoid spicy food, fatty food, and we're going to eat smaller meals. And hot herbal tea can help with some of those GERD symptoms. Constipation. Progesterone is also going to slow down GI motility. Iron supplements do the same thing, and that uterine compression is also going to worsen it because it's kind of blocking. We're going to teach our patients to increase their activity level, increase their fluid and fiber intake, and if they absolutely need to, they can take some stool softeners. Frequency. So the enlarged uterus is going to compress the bladder in the first and third trimesters. It's going to resolve a little bit in the second trimester, but it gets really, really bad in that third trimester. So we're going to teach them to make sure that they are frequently voiding, training their bladder. We're going to assess them for urinary tract infection. We're going to tell them to call the provider if there's any dysuria, cloudy or foul-smelling urine, or flank pain. We're also going to tell them about Kegel exercises and making sure that they urinate before and after intercourse. Leukorrhea. This is completely normal, okay? This is the increase in thin and white vaginal discharge, and it's caused by estrogen and the cervical gland activity. So we are going to tell them, do not douche. Make sure that you maintain good hygiene to prevent yeast infections due to now having an increased risk. Wear peri pads and report any itching, foul odor, or changes in character. And then Braxton Hicks. Again, more common in the second and third trimester. We talked about it a little bit earlier, but we are going to educate them on the difference between Braxton Hicks contractions and true labor contractions. That's going to be the biggest teaching point here. Okay, nutrition. So, in pregnancy, in the second and third trimester, your caloric intake needs to increase by about 300 to 400 calories a day because of the fetus, the placenta, and maternal tissues are all growing at the same time. Teach your patients that this doesn't necessarily mean eating for two. It means adding a healthy snack, fruits, vegetables, or a small little meal boost. Okay, we're not like pigging out. Also, we have to make sure that we're increasing our iron, our folic acid, and our protein, because those are going to be super important for the development of the baby, as well as the expanded blood volume. And the protein can help with the tissue growth of the fetus. We're really going to reinforce those prenatal vitamins, pairing iron with vitamin C, and making sure that we're choosing healthy protein sources. We're also going to avoid deli meats, unpasteurized foods, including unpasteurized milk. No raw milk during pregnancy. It carries the risk of listeria. If you won't have a turkey sandwich, you also should not be drinking raw milk. High mercury fish is another thing that we're not going to eat during pregnancy, okay? Because it can affect the fetus's brain. Teach your patients that if they really are dying to have a deli meat sandwich, they need to cook it and until it's like steaming hot. And no unpasteurized dairy. And stick to low mercury fish like salmon or cod. Also, there is an average weight gain that you can expect during pregnancy of about 25 to 35 pounds, and it's broken up by 1 to 4 pounds total within that first trimester. Weight gain is going to be minimal because the fetus is so tiny, and there's a lot of nausea and vomiting, so it's going to affect how much they're intaking. During the second trimester, they should be gaining about 1 pound a week. This is when most of the weight gain is going to happen because your fetal growth is accelerating, that blood volume is expanding, and your maternal tissues are growing. In that third trimester, it's still about 1 pound per week, but it's more of a steady gain as the fetus starts to put on fat. The amniotic fluid is going to increase a little bit more, and the maternal stores are increasing for breastfeeding. All right, into our sixth section, the fundal height. So, fundal height at 12 weeks, it should be at the symphysis pubis. And we are seeing now at this point that the uterus is rising up out of the pelvis. So the fundus is going to sit right there at the symphysis pubis. Before this point, you really were not going to be able to palpate the fundus abdominally. At 20 weeks, it's going to be at the umbilicus. The fundus reaches the umbilicus, and that's the major landmark because from here on out, the fundal height starts to correlate with the gestational age. And again, like I just mentioned, between 20 and 36 weeks, the fundal height in centimeters is about the same number as they are weeks pregnant, give or take about 2 centimeters. And this is one of the easiest ways to screen for fetal growth in the outpatient setting. You can even teach your patient how to do this. There are some deviations though, like if you have too much amniotic fluid or too little amniotic fluid, if there's multiple babies, SGAs, LGAs, all of those things are going to affect the size, the fundal height and size. But again, fundal height is a very quick and non-invasive tool that we use, but it's not going to match that expected pattern until after 20 weeks. And it's also going to help us investigate a little bit fetal growth and amniotic fluid after that 20 weeks. Right. On to our last section. GTPAL. What does this mean? It means that G is the total number of pregnancies that have been completed and or uncompleted. I'll explain what I mean by that in a minute. T is if that baby was term, born after 37 weeks. P is preterm, a baby born between 20 and 36.6 weeks of gestation. 0.6 is 6 days. A is fetal death before 20 weeks. It includes miscarriages and actual abortions. And then L stands for living children, and it includes children that pass on after birth. Now, use that as your discretion and make sure that you ask your teacher what they want, because this is how I was taught, but I have noticed that some people were taught that if it's living, then it doesn't include people that pass on after birth. Like you're going to ask them that. I was taught that it does include children that have passed on, but just make sure that you ask your professor what they want. Okay, here's a little example. Go ahead and pause, go through this, and then the answer to this is on the next slide. All right, so this is the answer. So their gravida, their total number of pregnancies is 4. They had 1 term birth, 1 preterm birth, which is those twins. Don't forget that twins count as 1 pregnancy. It only changes in living children. And then abortions, in this case, it was a miscarriage. They've only had 1. And they have currently 3 living children because they have twins and 1 term baby. All right, these are the resources that I used to make this PowerPoint for you guys. And that is all I have for you. This is me cheering for you guys. You guys are going to do great on your test. And thank you so much for watching. Bye.